Thank you, John. National health care reform has been a long time coming. There was a congressman named Claude Pepper who served in the House of Representatives for several decades until his death in 1989, and he fought for many years for national health insurance. Late in his life, he used to say he was still confident the United States would get national health insurance. It just wouldn't happen in his own lifetime. After he died, the story circulated that he'd gone to heaven and he got to ask the Lord one question: will the United States ever get national health insurance? And the Lord said, yes, it will, just not in my lifetime. I'm going to start believing that story is true if Congress doesn't pass legislation this time. We've come further now than we ever have before. For the first time, the House of Representatives has passed a bill for universal health coverage. 2 Senate committees have reported out bills, and last night, the Senate Majority Leader, Harry Reid, released the text of his bill, which he will be able to bring to the floor if he can get the necessary 60 votes to start debate. It's not altogether clear that he will, but he seemed pretty confident. The leadership in the Senate seems pretty confident that they will be able to bring this bill to debate and to move it all the way through. I downloaded all 2,074 pages of the bill at 8:40 last night. And I have to confess to you that I haven't yet read it all. But I read enough to persuade myself that it's within spitting distance of the House bill. And I'm certain some of the critics are going to put that proposition to a test. The problem is going to be getting those 60 votes in the Senate. If something passes in the Senate, I do believe they'll be able to work out the differences with the House. But we now have this 60-vote requirement in the Senate, which really is only developed since the 1990s. The use of the filibuster has become a routine matter. Legislation requires, therefore, not just a majority in the Senate, but a supermajority. If the Senate doesn't do something about the filibuster, the national government in this country is going to end up like California's, so deadlocked on critical matters that it becomes incapable of dealing with the central problems before it. Well, that's an issue for another day. The Democrats in the Senate are going to have to get 60 votes, and we will see whether they do. I want to say just a few things about the Senate bill in a moment, but let me first say what I think this battle in Congress is fundamentally about. It has become a test of the ability of Democrats to govern. Like the president I worked for, Bill Clinton, Barack Obama decided to make health care reform his top domestic priority after the economy. It was a bold move. So many before him have failed that the odds of enacting comprehensive health care reform always have to be rated as low. Congress has now worked on this issue for the better part of a year. Other legislation has gotten backed up behind it. The Republicans know that if they can defeat health care reform, they will have succeeded again in humiliating a new Democratic president, in neutralizing his agenda, and probably leaving him with nothing to show by the midterm elections. As a result, this year's battle over health care reform offers a striking contrast to earlier efforts. In the past, the decisive opposition came from interest groups, chiefly insurance companies and the American Medical Association, and to a lesser extent, the pharmaceutical industry. This year, however, the AMA is supporting reform. Pharma is more or less on board, and the insurance industry has been relatively quiet. The general approach that Democrats are taking doesn't threaten any of these groups. And just to make sure to avoid their opposition, Rahm Emanuel and congressional Democrats have struck deals with key interest groups. But of course, one group remains unmollified, and that is the Republican Party. So we have a new situation this year. The opposition to health care reform is almost purely ideological and partisan rather than based on interest groups. And what makes this especially remarkable is the actual structure of the proposals before Congress. The Democratic proposals are built around ideas that many Republicans used to favor. They leave in place the existing system of employer-based insurance, and they supplement it by establishing new insurance exchanges where insurers will compete for subscribers. In another day, these ideas could well have been the basis of a bipartisan compromise. Unfortunately, they are compromises with a Republican Party that no longer exists. In the late 1940s, when Harry Truman proposed legislation for national health insurance, what today would be called a single-payer plan, a group of Republicans, including then-Congressman Richard Nixon and Jacob Javits, advocated a system of government-subsidized, private nonprofit insurance with premiums scaled according to people's incomes, quite similar to the proposals today. In the 1960s, when Democrats were calling for a program of government hospital insurance for the elderly, Republicans countered with a plan for voluntary insurance for physicians' bills. The Democratic proposal became Part A of Medicare, and the Republican proposal became Medicare Part B, which is government-run but voluntary. In 1974, as president, Nixon sent to Congress legislation for universal coverage that relied on private insurance to cover the employed and a federal program to cover the rest of the population. National health insurance, Nixon declared, was an idea whose time had come. But because of Watergate, his own time had gone. If he had only been wounded instead of destroyed by scandal that year, he might well have struck a deal with Senator Ted Kennedy, by that time the leading Democratic advocate of national health insurance. As recently as the early 1990s, when Bill Clinton and other Democrats were again pushing for universal coverage, President George H.W. Bush and such leading Republicans as Senator Bob Dole and John Chafee countered with their own proposals for reform. Their bills would have expanded coverage by subsidizing private insurance, and Chafee's plan called for an individual mandate, a requirement that individuals carry coverage. In fact, back at that time, there was a lot of discussion in the media that Democrats favored an employer mandate, requiring employers to pay. Republicans favored an individual mandate. Now, however, of course, Republicans are denouncing the individual mandate that used to be at the center of Republican proposals. If the long line of GOP reform proposals prior to 1993 truly represented the Republican position today, a bipartisan compromise would be readily at hand. After all, the Democrats have moved toward what was once the Republican position. Their proposals would preserve private employer-based insurance. They would subsidize that insurance. For people without employer-based coverage, the proposals don't go as far as Nixon did in 1974 and create a federal program. Oh no, that would be too radical. Instead, they create an insurance exchange that would enable people to choose among competing private insurers and a public option. Oh. Historically, conservatives objected to Social Security and Medicare on the grounds that those programs were not optional. Well, this year's proposal for a public option is just that. It's optional. But today's Republicans don't like it any better. And it's not as though they're offering to support reform if Democrats will just drop the public option. Rather than searching for common ground, they've tried to arouse a climate of fear about reform. And so you have a phenomenon that I've called bipartisanship in one party. Liberal Democrats negotiating with conservative Democrats who have essentially taken up the position that moderate Republicans have abandoned. Well, now a few observations about the Senate bill that was released late last night. As you may have read, the estimate by the Congressional Budget Office is that it would cover an additional 31 million people, and including Medicare in the total, that would bring coverage in the United States to 98% of U.S. citizens, which would be a tremendous advance from what it has been historically. Because of the additional revenue it would raise and cuts in Medicare payments, it would more than offset its estimated 10-year cost of $849 billion and reduce the deficit by $130 billion. Now, those numbers are important politically. They're particularly important for getting the votes of wavering senators. But that's actually not what's really important in the bill. The big change is an institutional one. It's the creation of these insurance exchanges. The Senate bill actually calls them health benefit exchanges, where people in the individual and small group insurance markets would buy coverage. Today, those people get a rotten deal in the insurance market. Out of every dollar they pay in premiums, only 60 or maybe 75 cents goes to pay for medical care. The rest gets absorbed in administrative costs and profit. And many subscribers are subject to pre-existing condition exclusions and other limitations on their coverage. The legislation would eliminate those exclusions. It would raise standards for their coverage. And because of the exchanges, subscribers would get many of the advantages of people who work for large companies, advantages that come from the greater purchasing power of a large group, lower premiums with more of the money going to medical care, better value for their money. By aggregating so many people together, the exchanges create large risk pools, and that's a particular benefit to the many people in the individual and small group market who today face unaffordable insurance rates because of age or chronic illness or disability. In reading through the bill last night, I was struck by one provision that I hope gets some publicity. Many Democrats campaigning for office said they supported reform that would offer to the American people the same coverage that members of Congress get. And this bill makes good on that pledge. It would transfer the health insurance of members of Congress and their staff from the federal employees' health benefit system into these new insurance exchanges. I think that's very important in those members of Congress being able to defend this system as one that they're willing to put their own coverage in. The bill Senator Reid is bringing to the floor includes a public option. Actually, it's doubly optional. It's first of all optional for states, and then if a state offers it, it's optional for anyone to enroll. Even in this diluted form, I doubt that it will survive in the Senate. Either it's going to be defeated entirely on the floor, or the Senate will replace it will replace the opt-out provision with Senator Olympia Snow's trigger proposal. That is, there will only be a public option in states if certain conditions are met. Exactly what those conditions are, I think, will be a subject of negotiation. They could have to do with the rate of increase of insurance premiums. They could have to do with absence of competition in certain states. I think there are potential compromises on the trigger. And from my point of view, that's just fine. As originally proposed, the public option might have been an important means of cost control. But it has already been so compromised, even in the House bill, that the Congressional Budget Office estimates that it would enroll only about 2% of the population, and ironically, it could well end up having higher costs than private insurers. And this is a point I've been writing about for some time. The public option is likely to experience serious adverse selection. That means it's very likely to end up with a higher risk group of enrollees because private insurance companies have been very adept, have learned over decades how to shed higher risk enrollees. And they only have to make no effort to enroll them, make no effort to re-enroll them, for there to be a process over time whereby the higher risk people get concentrated in the public option. Now, the exchanges are going to have mechanisms to correct for adverse selection. This is where things get a little bit technical. There's going to be a reinsurance system for certain high-cost conditions, and that will spread the costs of those high-cost conditions over all the plans. And there's going to be what's called a risk adjustment system as well that's supposed to compensate plans that enroll a population with actuarially higher risks. These mechanisms are very, very important to making the system work. And let me explain for a moment just why this is so important. We have a private insurance market today where the logic is, the rational thing to do if you're an insurer is to avoid sick people. Now, in a way, that's completely nuts. But that is the way it works, because if you don't have sick people, you won't have high expenses, right? Your medical loss ratio will be that much lower. And so that makes sense from the point of view of profit-making insurance company. It doesn't make sense from the point of view of the public health, because the people who end up getting denied coverage are people who need help, who need coverage, who need treatment. We want a system, I think, where competition drives the insurers to perform better, to deliver value for money, to deliver better coverage at a lower price. And to do that, you have to knock out of the market these incentives to cherry pick, to cream off the best risks. And that's what these mechanisms, the reinsurance and the risk adjustment system, all this technical stuff, that's what it's aimed at doing. It's aimed at discouraging insurers from competing in the old way, and instead encouraging them to compete in a different way to improve the quality of care, to improve their service, and you know, that would be a true victory for healthcare reformers. But my worry about the public option is that it's very likely to accumulate over time a high-risk population. It could well become, in effect, a dumping ground for the sick. And if it does, it will fail to realize the hopes of reformers of a plan that can deliver better protection at a lower price. And that's the problem. So my view is that the public option is not the thing supporters of reform ought to be focusing on. They should be much more concerned with a number of other features of the legislation. And what are those features? Well, the first has to do with the structure of these insurance exchanges. The exchanges need to be built on a solid foundation, and that means they need a broad risk pool. Insurers can't be allowed to cherry pick the healthy and leave the exchanges with a high-risk population. That's adverse selection. That will drive up the premiums. The whole thing won't work very well. So my view is that the legislation should require that all health insurance in the individual and small group market be sold through the exchanges, so that you bring in that whole population, a very substantial population. That would prevent adverse selection in the exchanges. It would immediately get the exchanges up to a scale where they can deliver substantial savings to enrollees. The House bill has such a requirement, but on a very quick reading last night, I didn't see it in the Senate bill. I hope I'm wrong. I hope the Senate has that as well. A second issue has to do with the level of subsidies. Both the House and the Senate bills, as you know, have an individual mandate, a requirement that everybody have coverage. And this is a hard thing to explain to the public. I don't think either the President or members of Congress have yet done a very good job in explaining why there has to be an individual mandate. One of the things that the public wants from reform, it comes up on every survey, is that there no longer be these exclusions of pre-existing conditions. But if you have a system where everybody's guaranteed coverage and where there is no exclusion of pre-existing condition, then the rational thing to do would be not to buy coverage when you're healthy, just to buy it when you get sick. But insurance doesn't work if that's the way people act. health insurance can only work if there are healthy people as well as sick people with coverage. Because that's indeed the whole basis of the thing. The whole basis of the idea is that healthy people are paying in so that they can cover sick people. And of course, the healthy people sometimes get sick. But if you provide an incentive for people not to buy insurance when they're healthy, you're going to undermine the whole thing. It only works if there is that individual mandate. And I think it's crucial that political leaders and other people explain why this is a central feature. There's another advantage to the individual mandate, though. If you have an individual mandate, then insurance has to be affordable. The mandate is actually not just a mandate on individuals to buy coverage, it's a mandate on government to make that coverage affordable. It provides a pressure, creates a pressure on government to keep down the cost to individuals. And that crucially relates to the subsidies for low and moderate income people to be able to afford coverage. And in the long run, it's going to relate to cost control. Now, the House bill expands Medicaid coverage up to 150% of the poverty line. The Senate bill only to 133% of the poverty line. And both bills then provide subsidies on a sliding scale up to 400% of the poverty level. At the low end, both limit what lower income people pay for insurance premiums to 2% of their incomes, and at the upper end, the House bill limits their exposure to 12% of income, the Senate bill to 9.8%. The lower level is a good thing. What concerns me is that there are going to be some people who are, let's say, at 3 to 4 times the poverty level, who are only going to get very small subsidies, and many of them may feel that they're being forced to buy coverage that's too expensive for them. And there could well be a backlash. To avoid that backlash, the subsidies have got to be adequate, and there's going to be a range of different levels of insurance coverage. The bronze level, a silver level, a platinum level, I think those are the terms that they use. And so there are going to be cheaper plans, but cheaper plans mean that people will have more out-of-pocket costs. So it doesn't entirely solve the problem. As I said, we want better value for money. The exchanges can cut the administrative overhead that exists now in that individual and small group market. So they can do a better job for people. They can tremendously reduce the financial insecurity that many people face. But there is going to be a difficult point. As those subsidies wind down, as they phase out, there are going to be some people who feel that they're being forced to buy policies that are expensive. So we need adequate support there. Another key issue has to do with the timetable of reform. It was bad enough, from my point of view, that the House bill delays the opening of the new insurance exchanges until January 2013. The Senate bill now puts that date off to 2014. And to me, this is a huge mistake. Now, both bills do have some important short-term reforms that go into effect in the intervening years. So, for example, people who are now deemed uninsurable because of a pre-existing condition will be able to get coverage through a national risk pool that Congress is going to subsidize up to a total of $5 billion. And that's going to help a lot of people. The legislation closes up what's called the donut hole in Part D of Medicare as of 2010, and that's a big immediate benefit to the elderly. It improves the prescription drug coverage that they have. There are small business tax credits for health insurance that cover up to 50% of the premiums for firms that buy coverage. That's actually quite a big deal. And these are things that go into effect before 2013 or 2014. Insurers will be immediately required to permit children to stay on family policies until age 26. That may affect a number of you here in the room right now. That would go into effect right away. Those are all good. But the fact remains that most of the uninsured will not get coverage under the Senate bill until another 4 years have gone by. When we enacted Medicare in 1965, it went into effect a year later. Why do we need to wait? 4 to 5 years this time. The Senate bill is delaying implementation to cut the apparent cost of the program. After all, if you don't start reform until the 4th or 5th year, your 10-year costs are going to obviously look a lot less. Unfortunately, when President Obama spoke to Congress on September 9th, in what was really, I thought, a great speech, he set an arbitrary ceiling of $900 billion on the 10-year cost. And that, I think, is now coming back to haunt Democrats and, in fact, to boomerang on the president himself. Not only will congressional Democrats have to run in 2010 without most people seeing results from health care reform, Obama will have to run for re-election in 2012 without most people seeing results. That is asking for a lot of patience, and frankly, it's giving the opposition 2 elections to raise anxieties and reverse reform. The deadline for national implementation of this legislation, it seems to me, should be January 1st, 2012. The law should allow states to come into the program a year earlier. A state like Massachusetts, which already has a working exchange, could move very quickly. And the law should give such early action states incentives and startup funds as well as more control over the program. To pay for that faster timetable, Congress should make some hard choices about taxes. The conference committee, if it gets to a conference between the House and the Senate, could take some of the measures that both have proposed. The House and the Senate bills have different revenue measures in them. Well, they could take some of both and raise more than either has proposed. That would mean pushing up that 10-year ceiling of $900 billion, but it seems to me that delivering the benefits earlier is really worth it, is very, very important. There will be no long run for this program if in the short run people don't see results and they decide it was all a mistake. Well, I want to talk a little bit about the long run, about the very long run, the broad historical sweep of things. Months ago, I was asked for the title of this lecture, and not knowing whether reform would be approved or defeated or would still be hanging in the balance by mid-November, I said, well, let's call it Healthcare Reform, the Long View. And I do want to make good on that promise, but I will do so pretty briefly. So let me outline for you the argument of the book that I wrote some 26 years ago, Social Transformation of American Medicine, and then very briefly summarize the major things that have happened since then. Social transformation is divided into a book 1 and a book 2. Book 1 runs from the colonial era to just after the beginning of the 20th century, and it tells the story of the rise of the medical profession and its role in shaping the entire healthcare system. In the early American Republic, the social status of physicians was insecure. Their earnings were modest. The organized profession was divided and weak. By the early 1900s, not only had the medical profession's status and income risen, physicians had been able to shape all the principal institutions of healthcare, such as hospitals and public health, and to limit any efforts by government or private organizations to control their work. The final chapter of Book 1 is called Escape from the Corporation, and it discusses the success that physicians enjoyed during the early 20th century in limiting what used to be called the corporate practice of medicine and in preserving their own independence. Book 2 then takes the story from the early 1900s to the early 1980s, which is when I published that book, and it describes the transformation of healthcare into an industry and the ultimate undoing of the physician's professional sovereignty. The story here is the interplay of politics and the structure of healthcare. At first, the medical profession retained its power to mold public policy to fit its interests. Repeatedly, attempts to pass tax-financed systems of universal health insurance foundered when physicians, in combination with other interest groups, were able to mobilize sufficient opposition to reform. As a result, during the middle decades of the 20th century, instead of health insurance as part of Social Security, the United States developed a system of employer-sponsored private insurance. And in the same period, it enacted a series of government programs to expand the supply of healthcare resources, of hospitals, of medical research, and health professionals, and so forth. And even when Medicare and Medicaid were adopted in 1965, they did not interfere with the fee-for-service medical practice,